classes, right? And this, all the postgraduate classes are special classes, and definitely it's going to help you to hone your skills and we'll become better together, fine? Hello guys, welcome back. This is Dr Ranjith again, your pathology educator at Unacademy. So as we discussed the first case, we'll be seeing a series of pathology cases. This is especially for postgraduates. We have been running the postgraduate program in Unacademy for the past 1.5 months, and this was one of the first things we had on YouTube, right? The histiocytic lesions. We are going to look at one of the histiocytic lesions here. I gave a little bit of clue, but still we'll have a case-based approach, right? So we are in the middle of cervix discussion, which is currently going on live at Unacademy. I urge you, if you are in postgraduate, to join the discussion, and it might definitely help you. So this case was a 50-year-old person who had a skin lesion. So generally, skin lesion is something which most of the pathologists shy about, right? So we always think when it comes to skin, it's going to be dermatopathy. It's one of the niche field and it's a difficult field which is not concentrated much. So the same thing which we approach with the case, that luckily it was something totally different, which is not a routine neoplastic skin or non-neoplastic skin lesion, right? It's a low power image of the thing. So if we look at this image, what I can see here is it's completely pink in color, right? I have something, one great thing which we can observe here is I have slight delineation here. Maybe here it looks the normal collagen fibers of the dermis, and I think the adnexal structure is here as well, right? And it's a very scanner view. So I have a skin where the majority of the skin is occupied by something. So my first possibility looking at this microscopic image is something neoplastic of origin, because it's too big to be a non-neoplastic origin, right? Who could know that it could be maybe an leprosy with such an abundant histiocytic response? That also is possible, but still it's in a very low power image. I know there's some lesion which is occupying entire thing and destroying all the adnexal glands and normal skin lesion, the structures, right? So definitely first possibility, something of neoplastic origin. And to corroborate our findings, in the corner I do have a normal collagen fiber and the normal skin adnexal structures as well, fine. Let's go back. Now one more thing, again a low power, epithelium is not involved. So something which is not epithelial origin is there here in this microscope, fine. Little bit higher power, same focus. See, look at the collagen fibers, look at the inflammation, the dermis and the epidermis. Look here, now I'm kind of getting a input that it's more pinkish. It's more pink color. Even in this power, I can appreciate there's definitely a little bit of pleomorphism involved, right? So something pink color lesion. So I'm just going to go to higher power, fine. So this higher power again, it's definitely ugly. Lots of pink color lesion, definitely ugly, right? So when you have this amount of pink color lesion, it's kind of an histiocytoid morphology, right? Histiocytic morphology is a very big row of differential diagnosis, starting from non-neoplastic origin. I'm pretty much sure that it's not non-neoplastic from this appearance. It's definitely most likely malignant as well, looking at the amount of pleomorphism. There are few cells which are very ugly, right? So looking at this, it's ruling out all the benign and non-infectious, non-neoplastic etiology. Something neoplasm, which is definitely ugly looking. It's skin. So one of the greatest mimicker is going to be melanoma. That could also have the same appearance, right? Who could say that, right? But the skin overlying epidermis was a little bit normal, but still it could be coming from somewhere else and going deep inside. That's still a possibility. Second possibility for me is histiocytic rich lesions. Could it be a lymphoma? It could be. Lennart's lymphoma has lots of histiocytes like this. Could be a T-cell lymphoma, which is also common in skin. Could be a DLBCL, skin related, right? You can have the DLBCL of the leg, that could be that. We have T-cell rich B-cell lymphomas, it could be that. It could be any of these, right? So we went ahead with 2 panels of IC here. We did the routine. We started with the lymphoma in the mind, and also we had an epithelial origin also in the mind, because it was a bonker for us, fine. So CQ was negative, SN was negative, so melanocytic epithelial lesions ruled out. The CD20 was negative as well. Then we went ahead with more and more markers, and we finally got our answer in the second panel towards the end. Histiocytic marker was positive, obviously, so we didn't want to jump into the diagnosis of histiocytic sarcoma initially, or any of the histiocytic lineage sarcoma initially. We have follicular dendritic sarcoma and all of them, but still we went ahead with the diagnostic protocols, and what we did was, this was a CD8, 68. Definitely it's positive, it's abundant, right? It's abundant and it's positive in this case, and this was lysosome. So lysosome was not available, we had outsourced. And one thing I wanted to concentrate is, look at the lysosome. Somewhere it's very dark, especially if you look at this cell. It's positive in the cytoplasm in the form of granules, but here it says a slight patchy positivity, right? That's Golgi positive of lysozyme. That's very characteristic of this lesion, right? So with the extensive panel which we did, and only thing which I am showing you is 2 of them, which I am sure must be more than enough to arrive at a diagnosis. CD1A was negative here, so all the Langerhans cell etiology has been ruled out. So we narrowed our diagnosis to your histiocytic sarcoma. Fine. So we did see a case of histiocytic sarcoma just now, and we are going to see all the points relevant for a case diagnosis are nuggets from WHO, right? So most of the neoplasm we are going to try totally on WHO, and all of the next few slides are from WHO for your ease. The most common sites are extranodal, right? Intestine, skin, like I said, and soft tissue. Skin, soft tissue, like in a case, right? They do present with lymphadenopathy, but when it comes to the lymph node, I would think of an Lennart's lymphoma or an B-cell rich B-cell lymphoma as the first possibility, and histiocytic sarcoma lower down the road, right? Though the histiocytic morphology very classical, right? Systemic manifestations are extremely rare. The word malignant histiocytosis is kind of cat on the wall. Maybe in the next WHO it might go off as well. WHO has a clear indication of that previous histiocytic lesions has been totally reclassified into multiple newer lesions, right? I have not put the table. If you're going to be interested in hematopathology, I urge you to go to WHO under the histiocytic lesions. You might have a look at that, right? So when you go to the microscopy of this histiocytic sarcoma, they are definitely non-cohesive. Right? Proliferation of large cells, it was like a diffuse, like a sheet, entire sheet. It didn't have any pattern, just sheet. This sinusoidal distribution can be appreciated if it's in lymph node, liver, or spleen. If it's hematolymphoid, definitely the histiocytes are going to be more concentrated in the hematolymphoid region. It can be much more appreciated in your sinuses if it's in hematolymphoid tumors, right? It's not the dictum again. Even if it's in hematolymphoid tumor, it originates from the sinus. Let's say it's growing so aggressively, it'll expand the sinus and spread all over. Again, you'll have an effacement of lymph node or whatever tissue I'm going to take biopsy at. Fine. So when you go to the cytology of cells, do remember spindling is common. Though I have round to oval cells, we didn't have much of spindling. Though in the corner of the IHC of CD68 was a little bit spindle, right? That's where the CD68 was very good positive. So towards the corner, I had a little bit of spindling, but the main tumor mass had lots of large oval cells. Abundant eosinophilic cytoplasm, very characteristic of my histiocyte, right? You can have multinucleation, you can have irregular folded nuclei. I'm just giving you a hint that you might even sometimes mistake if it is in an let's say a lymph node. ALCL nucleus also will be very irregular, right? So I have lots of differential diagnosis if it comes in a lymph node, right? Histiocytic sarcoma should always be lower down the road. I rule out all other lymphomas where histiocytes are commonly seen. Then I'm going to think of an histiocytic lesion, right? That's how the approach generally is. So IHC is going to play a major role here in diagnosis, and the IHC what WHO prescribes is right here. I should have expression of one or more histiocytic markers. 163 we didn't have, CD68 we had, lysozyme we had outsourced, right? 160 was not available, so we went with these two. Both of them will be cytoplasmic granular positivity, and as I showed in the image, lysozyme staining will be accentuated in the Golgi region. This is what WHO says, and definitely if it is the case, all the things which are seen in the WHO will fit in. Evidence-based medicine at its best, right? And most important thing is, as I said, that CD1A should be negative. So when you come to histiocytic lesions, again there is a free session on Unacademy YouTube channel about benign and malignant histiocytic proliferation. Just go through a look, right? When you divide histiocytic lesions, Langerhans cell is one of the much more mature things. So CD1A will be positive only in Langerhans type lesions. I do have lots of other histiocytic proliferation like follicular dendritic cell sarcoma, your histiocytic sarcoma. There are lots of histiocytic lesions where CD1A will be negative, and again follicular dendritic marker should be negative, and other myeloid markers should be negative. All these negativity is required for me. We didn't do myeloid markers because we didn't have myeloid lineage in the differential diagnosis for us. We didn't think of an granulocytic sarcoma, right? It didn't strike, right? So it is more histiocytoid, and we went ahead with the markers. But if you're still having a granulocytic sarcoma in the differential diagnosis, do an MPO. It will be definitely negative in this case, and we had diagnosed it as an histiocytic sarcoma, fine. So we had seen a single case of histiocytic sarcoma. The case one what we saw was in cervix, and we'll have mixed bag of cases, so that will help us to refresh our knowledge. I would say store all the links system wise, so that when you have the exam, just hit click and keep binge watching. So it'll be a single case discussion which will help you from the start till the end, both histomorphology and IHC, and it'll be helpful for your Viva as well, fine. Do follow me on the Unacademy app. There are classes going for postgraduates. It might help you from the first year. till the final year, and we'll read it systematically, and we'll report the reporting guidelines as per the RST and CAP protocols. Fine. Thank you for your time, and I just want to repeat that all these classes are special classes which will be free of cost for all the postgraduates. Let's learn together and become better pathologists. Thank you for your time. Bye bye from Dr. Ranjith. See you soon.